Welcome everyone. Today's program is part 4 of the 4-part Critical Access Hospital Conditions of Participation for Hospitals. Over the last 3 sessions, we have covered almost the majority, if not most, of the entire Appendix W for Critical Access Hospitals. So now we're going to go ahead and wrap that up. You can contact them directly by email with your question. It takes them a week or so to get back in touch with you, only because they've been a little busy right now with the pandemic and all the changes. So again, this is part 4 of number 4. And of course, why we're here is so you do not get one of these, the Statement of Deficiencies and Plan of Correction. That's what CMS will send back to a hospital when they've come in, done their survey, and found that there are certain conditions or standards, tag numbers. What I'm covering today is what I've learned by keeping up with the Federal Register. The Federal Register is where the codes, the laws are written. You can also keep up with this. You can get notice of them and get email updates. Just enter your email address on this information from slide number 5. Of course, you'll have to go to the website and then enter it and hit submit. How do you keep up with the changes otherwise? You definitely want to make sure you have the most current manual. The last update was in February of 2020. Now, they didn't get around to finishing everything with that update, and so they are still having some things pending that need to be done. It's almost 2 years now. In fact, it was 2 years yesterday. Today is February 3rd. It was 2 years yesterday, and they still don't have them. These are interpretive guidelines and survey procedures that they did not get accomplished. And of course, this is what it looks like to go onto that survey memo site, the policy and memos, states and region. And again, that's what CMS sends to their surveyors to keep them up to speed. As far as how I come up with some of these topics and also where I focus education on, I look at the deficiency data, or the citation data, it's another word for it. Well, I'm going to start with radiology and nuclear med. Now again, some of these programs, some of these areas I'm touching on, they're usually anywhere from a 90-minute to 2-hour program in and of themselves. And so I'm condensing it down and giving you the really hardcore facts on what you would need for that particular section. So let's go ahead and start with radiology and nuclear med. Your radiology services, of course, have to be provided by qualified staff, just like with anything that happens in the hospital. The nice thing is you can do it through direct or contracted service, and that includes interpretation. Many of you probably do use a night service. I'm not endorsing it, but just one service is Nighthawk, even one for pediatric imaging. I've included in here the most, what it looks like for the ACR manual on contrast media. This is the one from 2020. By the way, on any of the links that I put onto the slides, type them in. If you try to do the link by clicking that on the site, it will not work. You will have to type it in or copy paste. And so that's why they put that in the Blue Book. Again, you're not required to do that, but it's a really good resource for us. Well, that's it for radiology. Let's go ahead and flip over to rehab. They're provided, of course, by qualified staff. Nothing has changed. It is the same. That includes PT, OT, speech, language. It is provided according to their state law. And what are the therapy requirements? What do you need to change? Again, rehab's a very short section, and it's an optional section. So if you are going to do it, you don't have to provide it through employees. You can contract that out to have that available. Visitation, these were some changes that CMS put into effect, and especially for the larger hospitals, they made some changes just a couple years ago, which I thought was very surprising, because we never had these issues, back in the dark ages when I was doing bedside nursing. Patients came in, their families and friends came to visit them, and then they went home. That was it. And then things started to happen. Other people wanted to visit that maybe they really shouldn't visit. The patient had no say in who was going to visit them, or that the patient would have too many visitors. And so CMS said, okay, maybe we do need to start looking at some policies here on it. I'm going to switch over to a major component called those medical records. Well, let's go ahead and switch over now to the CMS conditions of participation for medical records. You have to maintain a system for clinical records according to your policy and procedure. That means you have to have a current list of authenticated signature cards. Maybe it's computer keys codes or codes themselves. Signature stamps. We're going to talk on signature stamps, by the way. We used to do it that it was a handwritten signature. So we'd have our full name in print, then we'd have our full name in hand cursive. All right, let's move over now to one thing called QAPI. That's the easy way to say it. It's also known as Quality Assurance Performance Improvement. Well, back in 2019, CMS came along and rewrote all the requirements for critical access hospitals for QAPI. Given the extent the changes, the critical access hospitals were given more time to comply. They were given an additional 6 months from what the acute hospitals were. Well, of course, that time has come and gone. All right, so from QAPI, let's go to organ procurement. This includes tissue and eye. You have to have a written policy and procedures on how you're going to do this. You must, this is not optional, you must have an agreement with an OPO. If you have an OR and a ventilator, you must notify that OPO if death is imminent or if the patient has already died. All right, let's move on to swing beds. Now, overall, with swing beds, it's a very long section, very long. So I'm going to hit the highlights. Overall, there are 4 changes that occurred back in 2019. Swing beds provide long-term care services. So you have to meet certain conditions, and it's under the SNF care. What it allows you to do is use beds interchangeably from acute care or SNF level care, because that's what the patient does. They swing from acute care to SNF care, and it's all reimbursement and services. That's all it is. They will survey the swing beds when they're doing a full survey, but they will also do it if there's a focused complaint survey or if you're actually requesting first-time swing bed approval. It's a great way for PT, by the way. You can do that. But again, is it voluntary or paid? A paid prevailing rate. It all goes into the care plan. So let's talk about swing beds in general. The overall requirements, you must have discharge orders from the acute care. You must, of course, maintain progress notes for while they're there. And then a discharge summary. And, of course, you have to have admission orders for when they're brought into swing bed status, because you're discharging them from acute care and admitting to a skilled bed level. So what I wanted to do with just a little bit of time here is, while you're thinking about what Clear County, Clear Creek can do, I want to show you some of these resources. There was the crosswalk. This is when CMS changed all of the tag numbers for the critical access hospitals. Now, it is not complete, I will tell you that, because under especially QAPI, it lists all of the old tag numbers and none of the new ones. I've listed multiple websites here for you. The Rural Health Resource from HIPAA, AHIMA, I mentioned that they have the body of knowledge and practice briefs for you. Okay, so with that, again, overall in the resource section, you're going to see roughly about 30-some pages of resources. Some won't apply to you, but if that's what you like to do. Thank you, and stay safe, everyone.